from the media, good afternoon and welcome to this pre-opening ceremony ICASA press conference. At the moment we have Mr. Luke Amagodia, who is the ICASA CEO. He is here with us. We are also joined by the UNAIDS Executive Director, Ms. Winnie Bianyima. So those are panelists that we have at the moment. So we will start to hear from Mr. Luke, who is really going to unpack more about this international conference, which is organized by ICASA and SAR, which is the Society for AIDS in Africa. They are the responsible organizations for ICASA. Look over to you.
Thank you. Thank you so much, Daniel. Let me recognize the executive director of UNAIDS. Thank you so much for being very punctual, because we say 1 o'clock and you were there for 1 o'clock. I really appreciate that. As you know, ICASA, the International Conference on HIV and AIDS in Africa, is the conference that organized by SAR. Society for AIDS in Africa is the constituent of ICASA. And this society has been organizing ICASA since more than 33 years now. And we are here in Zimbabwe, is the 33 years of ICASA that we are celebrating. As you can see, the title of ICASA this year is very clear. You can see we talk about address the equalities, accelerate inclusion and innovation. It means what? It means that this ICASA is dedicated especially for inclusion. Without inclusion, there is no way we can reach the 95, and end HIV by 2030. I just want to give you the information that at this stage, we have more than 4,600 people registered in person. And we have 2,008 people online. This is the situation around ICASA today. Just to tell you that we are around 7,000 plus delegates here, both in person and online. And you can see the program. The program goes across all the spectrum of the health system. It's true, ICASA is HIV, but it's not only HIV, it's TB, malaria, and STI, as well as strengthening the health system in Africa. Now you should bear in mind that you as a journalist, you are the first. You are the one that carry the message from ICASA here to the world. Without your report, there's no way the vessels that we are sharing here will go out. It will not go anywhere. It will just begin for Zimbabwe. This is an international conference. We are having 133 countries that are present here. And please carry every news that you have here to the world. People are waiting to hear the great news here from ICASA. People are expecting great outcome from the community perspective, the leadership perspective, and also the scientific perspective of this conference. And only you can help us to carry it across the globe. Thank you so much for your time. And I think I will hand over to Taribo again. Thank you.
Thank you very much, Luke. I'm seeing the SAR president, Dr. Harare is walking in. So I am going to call upon the UNAIDS Executive Director, and after that we will then hear from the SAR president. Ms. Bianyima, it's over to you.
Thank you very much, Director of this press conference, members of the press, colleagues, the leaders of the organizers of ICASA, other stakeholders. Good afternoon.
Afternoon, ma'am.
It's such a pleasure to be here in your great country of Zimbabwe, and that we are all convened here to push, to fight, to reach the day we will declare that AIDS is over. This is a movement, and it's very energizing to know that over 5,000 people from all walks of life, activists, government leaders, scientists, pharmaceuticals. We are all here as one movement with one purpose, to end AIDS. This year's ICASA theme is AIDS is not over. We must tackle inequalities, accelerate inclusion and innovation to end AIDS as a public health threat by 2030. That target in the Sustainable Development Goals. We have a timeline, 2030. And time is short. We have 7 short years to go, and we are here to see what needs to be done to speed up and achieve that timeline. It's 40 years now, 42 actually, since AIDS was first identified. But we are still losing 1 life every minute. We've got 30 million people who we have got on treatment. This is a great achievement. 30 million people globally are on treatment. But there are 9.2 million others who are living with HIV who are not on treatment. We have to find them. We have to get them on treatment. And when we unpack that 9.2, who are those not on treatment, we see the ugly face of inequalities. It's people who face inequalities. Who are they? The majority of them are African, are on this continent. Because again, this is the continent that is most excluded economically, that is suffering the devastating impacts of climate change. Welcome, my sister Chidi, the head of AFRO, the World Regional Office for World Health Organization in Africa. Thank you for being here. So I was saying that inequalities are driving HIV, and we must tackle them to end HIV. I've gotten to the point where we say, look at who is still out there living with HIV, not on treatment, the majority are here. But even when you look here in Africa and say, who are those who we are failing to get on treatment? We have the tools for prevention, for testing, for treatment. So who are those who are not getting on treatment? Who are getting newly infected or who are dying? Again, we find that new infections here in this region. Last year, the majority of new infections were against who? Girls and young women. That is the face of new infections. And it is inequalities driving that higher vulnerability of our girls and young women. It is in the social norms, those social norms where men dominate women, men control the bodies of women, violence, sexual violence is tolerated in the society. You see teenage pregnancies rising, you see early marriages. So, social norms, the acceptance of male domination, the acceptance of violence and force in sexual relations, tolerance of that, is driving the infections of our girls and young women. But also the public policies that are not gender equal, that are not creating equality between boys and girls, men and women, are driving HIV. Millions of girls are not in school. School is the best space for protection. If a girl is 13 and she's not in a classroom, where is she? She's in an unsafe place. She gets pregnant. She gets forced to have sex. She gets HIV. So public policies that should equalize for girls are weak. Investments, public investments in the health of girls and women are weak. Why do we still have maternal mortality? Why are girls and women dying in childbirth? because investments in the health of girls and women are still low. So public policies that are not equalizing are a reason why we are not moving there. We need to equalize. Women's lives, girls' lives must be equally valued, and that way health services for women's health, girls' health, education for girls are critical for reducing new infections. So inequalities, closing inequalities in public policies on health and education and investments is critical. Who else is not? Who else is suffering inequalities in those numbers? Key populations. Amongst key populations, you have gay men, you have trans women, you have sex workers, you have people in prisons, you have people who inject drugs. All these groups, what is in common with them? They suffer some inequalities. They are discriminated in society, they are stigmatized, they are criminalized, so they are driven away from getting what they need. They don't come forward for prevention, they don't come forward for treatment, they die. So the new infections, the deaths among these groups are higher than for the rest of society because of inequalities. If we close those inequalities, we will equalize, their infections will drop, the deaths will drop. Zimbabwe is doing well. I'm happy to say at this press conference, Zimbabwe is doing well. Victoria Falls, I visited a center run by civil society, by an NGO. This center is targeting hotspots where you find sex workers, where truck drivers assemble, for example. At this center, I saw and met there sex workers who are receiving what they need for prevention, for treatment, for testing, and they are also going out in the community to find others to bring them to be tested. These centers are all over your 10 provinces, and they are supported by a favorable policy in our country, where the law, the Supreme Court, changed the burden of proof and shifted it, so that today the police, who were the main actually, they were the ones exploiting from sex workers and making them more unsafe, now are not arresting them, are not confiscating their tools, their medicines, and sex workers are now, we are seeing new infections amongst them dropping. Thanks to the work of government and civil society together, closing the gap for one group of people to reduce their risk of infection. So I would say more, but many things in this country are going right, in the sense that inequalities are closing, and those who need prevention or testing or treatment can come forward and get it with the support of civil society. I want to end by saying, on World AIDS Day, that is why UNAIDS and our Secretary General Antonio Guterres called the whole world's attention to the role of communities in this response. We said, let communities lead. Communities are not in the way. Communities light the way. We said communities have fought for prices to come down so that everybody can get antiretrovirals. Lives have been saved. That was communities fighting the companies and pushing for prices to come down. Communities, you know about the treatment adoption campaign of South Africa, one of the organizations that led the fight for prices to come down. Communities reach those who need. As I've mentioned, this NGO that's reaching sex workers, others that reach gay men, those who are discriminated, criminalized, are reached by their own and reached in dignity. community and are able to survive. So communities play that role of reaching those who need and connecting them to health services. Communities provide health services. Communities also hold government officials, health workers accountable to the community. We need communities to. So we are calling donors who are helping Africa to fight HIV/AIDS, not to stop at giving money to governments, but to give funding to civil society to play their role. This money has been coming down. We have the evidence, we track it. Civil society 9 years ago was getting about 30% of the resources coming in. Today, it is about 20%. Less and less communities means we lose the leaders of the fight. We are saying, roll back these laws that reduce the space for civil society to work. African countries have, over the years, recent years, been putting in place more laws to prohibit the activities of civil society. We are saying free civil society. Roll back those laws. And lastly, we are saying defend human rights. Governments stand on the side of the human rights of people, because those who need HIV prevention and treatment are also the ones whose human rights are violated. Give rights and we'll end AIDS. Thank you so much.
Thank you very much, Executive Director. I'm going to ask the whole regional Director for Africa, Ms. Masidi Somoeti, to also address the media.
Good afternoon. Excuse my being late. So I'd like to recognize the President of ICASA, Dr. David Paradonako, an old brother and friend. And to recognize my dear sister and colleague, Ms. Yarima, who is the Executive Director of the AIDS. And thank you for this opportunity to say a few words. I literally ran here directly from the airport. I just landed in Harare. And just to say, Harare is an old home. So at the time when WHO was rolling out a very important treatment access campaign, the so-called 3x5 initiative by one of our directors general, I was the head of the HIV program in the World Health Organization stationed here in Harare, leading all that work of increasing access, simplifying the approach to delivering HIV treatment to people from here in Harare. So I'm very pleased to have the opportunity to be back in the second home again to have this discussion to see, so where did we reach? What is it that worked well? And what more do we need to do? And thank you really for your very enough focus on what's really the most important aspect of this work. It's the people. It's the people who are affected. It's the people who are able to drive a response. So speaking from the perspective of the Specialized Health Agency of the World Health Organization, we are very much a partner within the UNAIDS family with all their organizations and agencies, is to say, first and foremost, starting from several decades ago when the pandemic started. And we have to remember it's a pandemic which is still ongoing, because our attention became somewhat distracted and attracted by the new pandemic of COVID-19, which was so dramatic. But this is a pandemic that has continued over decades, and I agree very much that we have achieved a lot. We've decreased the number of new infections, the number of deaths among all groups in Africa. We even organized, because we realized that, of course, I happened to be from the zone, we confess. And at one point, my country was the country with the highest level of prevalence in the world. And I used to walk around conferences as that woman whose country has the highest prevalence in the world. And so East and Southern Africa were worst affected, and a lot of effort, investment went into changing the situation. And as my sister Winnie was saying, countries like Botswana, Eswatini, here in Zimbabwe are doing well and have surpassed the targets that have been globally adopted to show that we are making progress, we are doing well. But we saw that Western Central African countries, which were perceived to have less of a problem, were really lagging behind. So here, we still have large, significant numbers of people who are getting infected and not on treatment. But we did a catch-up campaign several years ago and made a big difference in terms of the Western Central African situation. I'd like to re-emphasize as well the gender aspects and the inequities and inequalities because they are central to what is going on. If you look at our situation in South Africa, again, from my country, Botswana, it's a country that has, at least when I was a young doctor working in the public system, had some of the highest teenage pregnancies in the world. And that for me was a signal that young girls are engaging in sexual activity prematurely, 14, 15, getting pregnant, and of course when HIV arrived, getting HIV infected. We have made a difference to that situation, but it continues. They continue to be the highest affected, the most vulnerable group and key populations are also severely affected. So the one message that I'd like to leave here is that we have done a lot. Billions of dollars have been spent on the global HIV response. So in a way, it's a tragedy that after that amount of spending, we still have a situation where young girls and vulnerable groups that Dr. Winnie enumerated are still getting infected in our communities. So we need a people-centered response. We need a response in which people themselves can unleash their ability, imagination, capacity, and make a huge difference. So if I give an example of what communities did during the COVID-19 pandemic, when the health systems had to be closed down because of the fear of infection, it is at community level that services continued to be provided. So, and the HIV community who have learned over decades how to mobilize, how to empathize with each other, how to support and provide care and support for each other. One of the most important areas to recover from the impact of COVID and to in fact expand the services that were being provided initially for HIV, sexually transmitted infections, for other health problems, so that people were able to get treatment for other diseases using the mechanisms and the clinics that have, and the gatherings that have been organized by the HIV community. My view is that these need to be maintained. We should retain and support this capacity to reach out to communities and provide them with care, because it's a way of expanding our healthcare systems in the African region. You may not know, and you may have heard lately, a lot of discussion about primary healthcare at the level of political leaders, international organizations that are working on health, re-emphasizing something that we started working on 40 or so years ago. But we've recognized that the kind of investments that were made initially in primary healthcare have not been sustained. And we know that communities extend and expand the reach of primary healthcare with their own resources, with their own networks to some of the most marginalized and excluded people as far as healthcare is concerned. So my strong recommendation is that we need to recognize and help to fund these so that they expand the healthcare system, not only to the most vulnerable, marginalized groups, but to the general population, because that is what they did during the COVID-19 pandemic. When decisions are being made, the people who are most affected by HIV/AIDS need to be in the room, need to be around the table. Whether it's in a village, whether it's at a district level, whether it's in an NGO, whether it is a national council that is deciding what should happen, how money should be invested, what actions should be taken, if the response is working or not. So I would like to reinforce the advocacy. We need to engage much better than we are doing with people living with HIV, with the communities that have been such an integral part, a very creative part, a sometimes unrecognized part of the response to HIV. Let us bring them into those hollow halls where decisions are made by our political leaders, by our technical leaders, because what they know from personal experience, what they know from the suffering and the ingenuity that they've had to call upon in order to have access to treatment needs to be put into the mainstream of policies and strategies to the benefit of everyone, including these marginalized groups. This is what we'd like to see happening in WHO. So to conclude, we've made progress, and I think we need to celebrate the progress that we've made. However, we recognize that we could have gone much further if some of the statements that were being made 30 years ago, I have to recognize I'm an old woman working with HIV and AIDS, 20 plus years ago, had been translated consistently in all the countries at all levels into policy, into engagement, into enablement, into resource allocation to communities for the work that they can do. If we look at innovation, because that's part of one of the important themes of this conference, no groups have been as innovative as people who know that their lives are at stake. For many people, it's a job. You go to work. For some of us who work on HIV, you work 24/7 for 20 years, but still, it's a job. It's not the same as when it's your life and it's your survival that's at stake. So we need to take on board all those innovations. We need to ensure that they are funded and they are incorporated into the policies and strategies of our countries as part of the mainstream. Because only then will we collectively benefit from the suffering, the struggles of this community that has survived so bravely. In terms of innovation, one example that I'd like to give. A couple of years ago, a group in the US that's working on developing gene therapy for HIV as a cure for HIV had a meeting to review where are we, is this going to be possible or not. And there were some youngish people who have been living with HIV for 10, 15 years who were part of that conversation. They said to me, we are prepared to do anything to support this research. We are prepared to be research subjects, to mobilize the community, to take part in that research to find the gene therapy to be a cure. Because I am exhausted of taking this treatment every day. I would like to be free of the need to do this. So people living with HIV have declared they're ready to be there as part of finding new treatments and meet research subjects themselves. So let us mobilize and support them. If there are new innovations being worked on, let's work with those communities. They have the most at stake in making sure that there are new advances in technologies, in treatments. So again, I hope very much that we'll come out of here with some great ideas about how to take that forward in WHO. We work in supporting governments to develop their health policies, to implement their health policies with partners, and we very much welcome the contributions and the engagement of the communities working with us and working with governments. Thank you.
Thank you very much, Bendu. Regional Director for Africa. I'm going to call upon the SAP President, Dr. David Nyatwa, and he's going to be the last presenter to us, and then Anna will take over from me after this.
All right. Thank you, Anna. You will take over. Yeah. But let me recognize, really, thank you very much. Very passionate. For the allowed, they should have gone on for a few more hours because it's going to be 16 minutes. Share with us. Let me recognize my sister here, Tidi Moeti, the Regional Director for WHO in Africa. I'm really happy that you are here. Thank you. But also, I want to recognize the media. All of you, you are the important ones today because we want the message to go through. And that message, if it doesn't come through you, it will not get to the people. Now, SAA, Society for AIDS in Africa, was born in 1987 in DRC. And the whole idea there was to say, initially, HIV, we're having conferences in Europe, Paris, Canada, and so on and so forth. So this group of people, scientists, leaders from Africa said, no, let's have our own. That's how Society for AIDS in Africa was born. To say, let's pan-Africanize the struggle. And SAA is the custodians of ICASA. You know, people saying, what is ICASA? International Conference Fighting AIDS and STIs in Africa. So, SAA are the custodians of ICASA, which happens every 2 years. Last year, it was in South Africa. This year, it is here. We were pleased that we started with a nice pre-conference in Victoria Falls, with the First Ladies articulating issues, including women here, and WHO articulating issues to do with transmission of HIV from the mother to the newborn child. And it was a big success. And I think that is what we wanted. Now we're here from today on. This is the real ICASA. And you are part of promoting that. We will be here from today, the 4th, to the 9th. And today we will have the official opening by the President at 4 p.m. And I know that today I just came from the airport. We met one of the other presidents who came in to just put his stamp on ICASA and the fight against HIV and AIDS. So 4 o'clock will be an important one for you, the media, to pass on the message. HIV has been with us for a long time, but many advances and progress has been made. And we are really pleased because our scientists, our leaders, the technical people are always there to give direction as to where we should go. So in this particular conference, there are 3 major areas that we concentrate on. The first one is science. Anything that we do in fighting HIV, we should center it around science. The second one is communities. You have both emphasized the issue of communities. And I know when you have got almost a paper on communities. Communities is the second issue. In all its forms, including the media is part of community. So science, community, and the last one is leadership. So we expect leadership from yourselves. Leadership, if there's no political will, if there are no leaders within the community to carry forward the messages, then we will not win. So yes, those are the 3 major issues, and let's carry on. There are about 23 plenary sessions, over 80 special sessions. We also have a lot of satellite sessions. So we have a lot of researchers, a lot of scientists, a lot of leaders, a lot of doctors, society people, people living with HIV, all sorts of spectrum people are here. And we expect to have a very, very useful conference. So those are my few words. Welcome, UNFPA. Who is taking over? We are taking over. Okay, the volunteer there is taking over. So thank you very much. This is a good press conference. Maybe we'll hear from you now whether you take over or not, but I think I don't know whether I will.
Yes, they are. And thank you, Dr. Prevention. True. Are you still Dr. Prevention?
Yes. Yes, it never ends.
It never ends.
Yeah, when I was Minister of Health, that was my theme. That when you're fighting HIV, 3 strategies, only 3. The first one was prevention. And the second one was prevention. And the third one was prevention. It did work.
Thank you so much. So you see, I was right. We will probably get time for 1, 2, 3, 4 questions because I know that there are other sessions that are currently going on. But at this point in time, I do want to give a chance to Ms. Lydia Zikomo, who is the UNFPA Regional Director, to give a few remarks to our journalists who are here. Please come through.
Thank you very very much. It's my pleasure to be here. I'm representing our Executive Director, Dr. Natalia Cannon, and representing the United Nations Population Fund. We're also, our structure is also Sexual and Reproductive Health and Rights Agency. So in terms of ICASA, our main focus is exactly what Dr. Karena was just saying. We focus particularly on the element of prevention. And in this region, specifically of Eastern Southern Africa, we talk about UNFPA has 3 zeros that it focuses on. Like UNAIDS does the 95, 95, 95, we have 3 zeros. So UNAIDS is like a catchy way of expressing our strategies. And for us, they're very simple. The 3 are ending preventable maternal deaths, ending unmet need for family planning, and ending gender-based violence and harmful social practices. But in this region, we also have a 4th zero, which is ending sexual transmission of HIV. And that's an acknowledgement of the purpose and the objective of this conference, which is that if we cannot address what's happening in respect of the interrelatedness of teen pregnancies, inadequate information on sexual and reproductive health and rights by young people so that they can protect themselves, they can exercise their bodily autonomy and have the choice in terms of when to get married, whether and when to have children, how to space their own children, then we're not going to be addressing the particular needs of families. And for this sub-Saharan Africa, and I'm sure you've heard from others already on this panel, that one of the big issues that we still have to get a hold of is the numbers of young and adolescent girls who are still being the victims of new HIV transmission. So to shine a spotlight on that key area of our population, who are also our future, by the way, we really have to take this fight seriously. But we're also hopeful and believe, like many of my other colleagues here, that HIV is a winnable battle. And therefore, it's worth us putting all the effort and our resources together collectively to fight that battle and win it by 2030.
Thank you very much. And I think we can give a round of applause for all our panelists. So in the interest of time, I will ask for 4 questions. So 4 people who've got many questions. And you can ask to any of our panelists. Do we have another microphone? So I'll allow 2 questions now and 2 questions after the answers. That's all right. Michael and John, okay, go ahead.
My name is Michael Marisa. My question is, I'm a journalist with the Health Times. My question is directed to Ms. Winnie from UNAIDS and probably Dr. Mwete. Since we're at ICASA, we are discussing science and HIV. I just want to find out how is Africa faring as far as advancing HIV research that is not, that is being done at an African level by Africans. Thank you.
And John?
Sorry, mine is not a question, but maybe a request for intervention in the media. This is a media center, and when there's a press conference, you expect maybe some calm outside, order within the area, and even when we're working here, I think some people don't even understand the nature of our work as journalists. I think we recorded almost 3/4 of voices there. We're not going to use them because there was a lot of noise, and some of the sound was not good at all. Please get intervene so that you're protected.
Thank you. We'll take it up with the corrective authorities. Would you want to go and Dr. Willie? Start with Dr. Willie. The doctors? It's a battle of the doctors.
Thank you very much. I think that a lot of research has been done in Africa. And we acknowledge that much of that research has been financed Oh, because they want to Oh, I need to stand up and speak into two mics. Okay. No. Just to say that a lot of research has been carried out in Africa and increasingly with African scientists. So I would say that the researchers in universities, in different institutions in Africa have really participated in research. Most of the funding for research has come from some of us, it's international financing. So I think there is something to be done. And of course, the research is done on African people. So I think we can say that African people have participated in research to discover tools, new ways of doing things, to contribute to knowledge and action and outcomes as far as HIV is concerned. If I can cite one major European initiative on research called the European Developing Countries HIV Research, hundreds of millions of dollars have been invested in this. It has trained lots of African researchers. They've engaged in research on all types of aspects of HIV and other communicable diseases. What is the gap is the translation of this knowledge into the production of tools engaging African institutions and African societies. So what is really needed, what would be great, would be additional, much more investment by African governments into some of this research. I think it would help there be a sense of ownership, there be the interest to translate the knowledge into tools and integration into the health services in Africa. In general, not generally in HIV, but in health research in general. It sometimes takes some years for the policy in Africa to take on board new knowledge, new tools, and scale it up as far as health systems is concerned. And part of this, we think, is the gap between the policymakers' ownership of the research and the policy process. That in HIV, of course, there is a strong, because HIV is a pandemic, as I said earlier. So even if we sometimes don't speak about it that way, we realize that one of the worst health events in history ever. So there is exposed communities that are pushing to know this latest technologies, how this knowledge is out, can we adapt the policies. We have a lot of that conversation. But really, there is room for improvement in investment and connection to service delivery. But there has been a lot of improvement in research. The scientists have, I guess, the financing, and what we also would like to see is the transfer, perhaps by the international funders, of the funding directly to African institutions. Very often it's a training arrangement with the university and the rest of the country.
I agree entirely with my sister Chidi on that very important question you raised on how much research on HIV that we are doing here on our continent. Let me put it to you. If I asked you that who invented salsa or cocoa, which you eat, can you tell me? Who invented it? You don't know, but everybody knows how to make cocoa. Everybody knows how to make salsa. This is the local knowledge of people of Zimbabwe, right? Yes. We have traditionally innovated scientifically and otherwise as communities and shared our knowledge, and it is owned by us as local knowledge, right? However, in other regions of the world, knowledge has been developed through methods where it is owned individually. You find that a research can be done here. As Chidi has said, our scientists here may take part in clinical trials for all the medicines we have here for HIV. Our own people living with HIV will put forward their bodies to be tested on for these treatments. But at the end of it, when there's a breakthrough, one person or one company somewhere in the rich country puts a label on it and says, it's my knowledge. This is the system of intellectual property, where knowledge is owned, is privatized, but actually the people who contributed to it are so many. So we have been pushing hard on this question of access to medicines, innovations, because unless we can accelerate and make sure that every new treatment that comes to market reaches those who need it most fast, that those who need to get it fast, those who need it most, we will not end HIV/AIDS by 2030. We have only 7 years. We need to get the best that research offers, the best technologies to the people who need. Right now, we are in a tough conversation with one company that has something called long-acting PrEP. This is an injection which you can get, and in 2 months, you will not get HIV if you have sex with someone who is positive. It's a preventive. It is also being developed to be maybe in 3 years for an injection that's once in 6 months. So in a year, you may just get a jab twice and you are good. Whoever you sleep with, whether they're infected or not, you will not be infected. This is a game changer. This can be a game changer for key populations who are hiding from the law, who don't want to show up, for girls and young women who fear stigma, and this taking a tablet every day exposes them. So this could be a game changer. But today, this injection is available. I see billboards in America telling people to come for it. It's not here yet. Not in our countries yet. Because somebody has owned the knowledge, the research, and has said, it's mine, and I will sell it at the price I want, and if you can't afford, too bad. This is a system that is unjust of intellectual property. Knowledge should be shared, especially when it's life-saving. It should be shared. And so we argue about the reform of intellectual property rules so that we can get access, equal access to the best that science has to offer. Thank you.
So can I get a microphone to Shoba and to Catherine? Maybe introduce yourselves and where you're coming from and then ask questions.
I'm Shobha. I come from India, which I'm sure all of you know. With the medicines made by generic companies in India, I think we are doing our little bit. I'm very happy and really all the speakers, they have spoken so well and touched, I think, some chord in our heart today. My question to all of you is that 5 countries in Africa, they have achieved the 95, 95, 95, much before 2025. What have they done differently? And what can be emulated by other countries, not only of Africa, but elsewhere also, so that we are on track? Thank you.
Good afternoon. My name is Catherine Robetsi. I'm a health science journalist living openly with HIV. So what has been said today affects me on a personal note. Thank you to Dr. Mansidi Somweleti on the progress made by Botswana on that HIV and AIDS was the face of women and girls, and that the incidence now has gone down. When you talk of science and research, it touched me personally because the pill burden is real. And when we talk of pill burden, when we have such innovation, science and innovation, when you say that science has now, as a health science journalist, I'm blessed. I know that there is now the injectable carbotigravia. It's something that we've been reading about, The science and research is done in Southern Africa, but when the medication is now available, it takes ages to reach Africa. Yet, we would have participated. I followed the gene therapy because it is something that I look forward to. I hope that treatment through gene therapy, a cure, will be possible in my lifetime because the pill burden is real. People who miss doses, they are not reckless. They are tired. They need a treatment back. And in August and September, sorry I'm taking too long, Zimbabwe had the community-led monitoring, and I was privileged to be part of the PEPFAR and AIDS certain people Ministry of Health to do the documentation. The stories in the communities, they are quite sad. The treatment literacy, there are gaps in treatment literacy. After cyclone we die, people, they don't want to be called patients because they are now living normal lives. But after the cyclone, everything was lost. They didn't know what treatment they were taking. The clinics, everything was lost. So we are feeling that this digitalization.
So I know who wants to be the first to come to the podium. How did those countries that reach the targets of the day, what do they do right? And then maybe a response to get
5 countries have hit the targets well in advance. Zimbabwe is one of them, Botswana, Eswatini, and Tanzania. And we know why. 4 things I can count on my fingers. 1, they follow the science. They address their real epidemic. They look at the data and they say, okay, these are the vulnerable people, these are the reasons, this is where we put our focus. So following the science, making your response responsive to your data, that's critical. Some countries want to address the epidemic that's not theirs. They may see that it's rising in key populations, and they may say, no, we don't have key populations here. Then you're not following the science. So follow the science. 2, they let communities lead. The governments of those countries work in partnership with communities to deliver to that last person. So getting communities to play their role, to hold you accountable, to deliver services, letting communities lead. 3rd, the enabling environment, particularly the human rights issues. In many of our countries, we have criminal laws. Criminal laws against men who have sex with men, sex workers, and so on, trans women. In many countries, with those same laws, they also do not enforce the laws because they want people to access services. So you can have the law, you can have the law and not enforce it, you can repeal the law. All those are options. Some countries see that these laws are against public health, they are abolishing them. Gabon, Botswana, Angola, many countries are doing this. That's good. Others, for reasons of the attitudes in society, the support there is for the criminal laws, they choose to keep the law but not to enforce. A country like Zimbabwe, actually the Supreme Court, the Constitutional Court amended their law such that now there's no prosecution. So the law is there, but it's not being enforced. And so you see all program of sex workers, they are coming forward, their infection rate is close to that of the general population. It's coming down. So human rights, enabling environment is critical. And the last one, the money. You must invest money. You must fight this disease, and it worries me that we're seeing some donor fatigue, yet it is the time when our countries here in Africa need that solidarity. We are being hit by climate change, we didn't create it, it's taking away resources, while taking away development gains. We are highly indebted countries. servicing the debt is taking more money than health of people. So this is the time when the global solidarity, the resources should be maintained so that we can deliver and end AIDS. So those four things, in these countries where there's progress, you have strong global solidarity, Global Fund, PEPFAR supporting strong, you have an enabling environment, we have communities in partnership with government driving the response, and they are following the science.
Thank you very much. Just to add one or two ideas. In a way, ironically, some of the countries that have done best are countries that you might think don't have a good health infrastructure. So Botswana, my own country, for example, it's only recently that Botswana has had its own medical school. So the doctors being devoted from all over. It's likely it's been a middle-income country for a long time. So it's one of the countries that really put in place a primary healthcare system. That we've been talking before about communities. So it's at the primary care level that you get that interface between communities and the health system. And so when Botswana had to roll out the HIV treatment, we didn't have many specialists. We didn't have big hospitals. Because part of the delay in some countries was that HIV was regarded as such a complicated, difficult disease that it stayed in the hands of specialist doctors. And we know that we don't have enough specialist doctors in our country to be everywhere, so the access was limited. I recall when we were driving the 3x5 initiative, one of our key strategies was to decentralize access to care, simplify access to care. This is what we call task shifting. In short, something that would normally be done by a specialist physician. If you train, if you have a clear guideline, if you supervise people at the peripheral level, it can be a general doctor, it was even nursing, because that was the nature of our health system. So Botswana already was providing healthcare, and Eswatini as well. It's a country I know well, I went to school there. Yeah. So it's having that idea of pragmatically using the capacities that you have, but making sure that you scientifically and responsibly provide the training, guidance, supervision, support for other cadres who are available in your healthcare system to provide care. Those are one of the drivers in Zimbabwe being able to stay there. And these were countries that also took some risks. I recall when we advised Botswana that keeping a secret is one of the main barriers for people having access to care. So find ways to encourage, support people living with HIV, to reveal to their families, their loved ones that with HIV will support. It was extremely difficult. But the government took that on as a policy and supported it. And then finally, leadership and investment. At least, I'm sorry to keep talking about my own country, it's just a coincidence that it's one of the countries that was a middle-income country that invested in its own with HIV. Hugely. I remember meeting an official from one of the wealthy countries in a meeting who said to me, your country is being irresponsible in financing the HIV response itself. You are holding out false hopes to other African countries. That is, yes. I will not name the country, but a very senior official from the development agency of a Western country who was outraged as an African country would decide we're going to put up, we have something. And then that came as a huge cost. We're going to put it into the HIV response under ex-President Buhari, and he was like, this is different from the usual recipient donor relationship in doing development. And your country is holding on false hope. I think that was wisdom, and we know that it came at a cost to other things, but HIV was there. 30+% of young people infected with HIV at some point in our country. So I think it's those leadership taking difficult decisions and working with what you have and adapting with the capacity that you've got. Being very clear what is your objective and then following the science. I agree very strongly with you.
Dr. Barilla, any comments as well?
other thing that I think is important is looking at patients, but maybe human beings as human beings. So looking at the holistic person. So this is something I think we've been also looking at in terms of the health system itself and how the health system works with communities coming forward for treatment or diagnosis or whatever. So providing an integrated package so that when someone comes, for instance, for antenatal, that do the HIV testing and counseling. Don't do these things as linear, silo, vertical processes, because a human being is made up of all of these things and we should address them holistically. So I think that an integrated approach within the health system in terms of ensuring that women, when they do come, and girls, they get the whole integrated package of care and their referral pathways available, and that health professionals understand that. Linked to that is ensuring that they're adolescent-friendly health services. Because if we turn away young people when they do come forward, we have lost the battle. Because then they will go and take risk-taking behavior, there's no prevention that they understand, and they expose themselves to all kinds of diseases and problems. So making sure that we've got adolescent youth-friendly services is essential. There was a point that was made that I wanted, that was made by Winnie, I think, on policy. And I think it's so important because sometimes we do fight to repeal the law. And as a lawyer, I can tell you that it takes a lot to get people to repeal the law, ministries of justice and governments to do that. But sometimes understanding that a law can exist but it's not applied can be good enough for now, while we fight the big battle for the future. And I think in Africa we should look at it from that perspective. But one element I wanted to say in this regard is that we do also have to monitor what's happening around ages of consent. So ages of consent, which is important to prevent early and child marriage, is also sometimes then having a backfiring impact in terms of then some in the health system thinking that that means that young people should not be able to access services, sexual and reproductive health services, until they are over 18. You know, but we can marry them off before 18, but they can't access services to protect themselves. So it's a contradiction in our cultures. And would I say, Dr. Patrick, it's maybe from the male patriarchal, but reinforced by women as well. But we need to work on that. We need to work on that because we say in one breath, young people are too young to make decisions about certain things, and we make those decisions on their behalf. Then in another, we expect them to take the consequences of things they are not in control of. So that's one area I think we're working around. Age of consent should not mean denial of access to sexual and reproductive health, including HIV treatment and testing and everything else. The other point I just wanted to make into what Manuel Benzi was saying there was in relation to Catherine Roberts was saying is a good point. And I thought, Dr. Betts, you might mention the Africa Health Medicines Agency that's being created, because I think that's the only way we're going to deal with some of the issues you're talking about. The length of time it takes and the delay it takes for us to approve certain things country by country in Africa. So maybe treatment regimens, drugs, could we, if we're doing this whole Africa free trade continental approach, do the same with our drugs and R&D, such that not every single country has to have its own way of approving what is able to be prescribed and available to women and girls and men in their country. Maybe that might help. So I'm hopeful about this agency, the health agency that's going to be started, because hopefully that will provide a way. But I also wanted to say that we as Africans need to understand what we have. And I don't think we're talking enough to the big pharma and small pharma, as well as those working in sort of research and development enough. Because at an Africa Health Summit that was held in Kigali 2 months ago, was the first time I heard that Africa has the richest genetic base or registry in the world. I didn't know that. And you know, at my age, and as a professional, So if that's me lacking knowledge, how much more in many African communities? And that this is actually one of the richest resources we have as a continent, which we are not taking ownership of and control of enough. Because in that genetic registry exists a lot of the work that could be done around appropriate, targeted drugs, treatments that work for Africans. And actually, if they work for Africans, they probably work for most of the world, because this is the cradle of humanity. So some of these things are important for us to begin to become literate on. We need to become economically literate to discuss and ensure the right financing. But we also need to become, to some extent, medically literate and scientifically literate to understand what resources exist on this continent and whether we are actually taking ownership and control. And the rallying call in that meeting was that African governments and African civil society and everybody else who believes in and works for Africa, we need to come together to take control of this area of research and development and what's happening around it. And I do believe that that's possible. And hopefully this African Health and Medicine Agency will be part of that. But also that in this work, we look at what happens when there's a crisis. Because one of the things we do see is that when there's a crisis in countries, Winnie talked about the fact of humanitarian crisis linked to climate change. And whatever, it could be conflicts linked to political, but it could also be definitely climate change. We have a lot of people on the move on this continent. We host the highest numbers of refugees and internally displaced people on the African continent. Now, within that, the highest number of those people are women and girls and young people. Reproductive function doesn't stop just because the crisis has hit. And we know that actually gender-based violence increases in these types of situations. And women and girls are not able to access what they need to protect themselves from HIV and STIs and even unplanned pregnancies. And for those who are pregnant, that they get the right care and support during that process. And again, we don't see the rise in mother-to-child transmission during that process. So also looking at what's happening on this continent in the humanitarian perspective is important, and ensuring that women and girls do not lose access to prevention, treatment and care during the time their lives are at their most chaotic and disrupted is also important. So I think all of these things are being worked on, Catherine, and we should have hope. But yes, it's just a bit too slow, and we need to push that we speed up on all of these initiatives.
I do not to stop you from this chance.
No, I think that we will exhausted. I was just going to say that whatever we do, the multi-sectoral, the multidisciplinary approach is the right way to go. Because all these things, you can see the socio-economic part, you can see gender-based violence, you can see the medication, you can see the issue of funding. But if you are going to fight HIV and AIDS, actually, you need a driver in each country. If there's no driver, you have all these ideas floating around, but you need someone who just holds it and drives it. And that is what is held certain countries. So we need a driver in each one of our countries, in each one of our regions. That driver will just capture everything and then say, but this is where we're going. And you don't see that.
Thank you. Just one last point. I think that, anyway, the perspective, the start of the pandemic response, the HIV pandemic, it was very much, we must save lives now. We must do whatever it takes now. I think we're at a point of transition forward where we're going to live with this for a long time. We are living with other things at the same time. How can we make the connections between what's happening in HIV and what's happening more broadly in terms of science, development, taking control, if you like. There's a lot of discussion now about taking control, Africa taking control. What does that mean? I really think we're at a kind of inflection point where the way of doing things, the way of thinking is needing to change, and it's starting to change. There's a conversation going on now among the global health initiatives, so the Global Fund, all the bodies that are given billions of dollars to provide support for different health problems. And much of that is being spent, at least by, if I take the Global Fund, in Africa. There's a conversation going on finally about what we've been saying here. We have to work together through the health systems of these countries. We can't have our own systems for our own diseases, which is a massive inefficiency, and which is a burden also on people who are working, particularly at the peripheral level, but at all levels of the health system. So the big question for me is, one of the conversations that needs to come out of this conference is, how are African countries going to take control of that discussion? Because that's coming from global health initiatives themselves. It may be that it's a response and a recognition of the missed opportunities to develop these systems over 20 plus years of very vertical working, so that we could have had much more impact if we had found, and it's not easy, if we had found ways to work together, how to train health workers at the most critical level, how to have procurement systems that don't buy what we need for each program separately, which is massively inefficient, and did not develop the national system so that they can buy everything else. Leverage that investment to buy everything else. So for me, what's needed now is for this to be picked up by African leadership to say, this is how we are guiding you and asking you to invest so that it works for us and improves also the way that the investments done by governments work together with this funding. And that's going to provide more people-centered care, better integration in the health systems. And I hope there will be lots of conversations here during this conference about how to drive that, because it will go further and it will enable, for example, even coming back to the regulatory bodies. In the region, we worked a lot with the national regulatory authorities around childhood vaccinations. We have a network called Harare where they pool resources, approaches, so when a new childhood vaccine comes, they work together to say, okay, how we, I left with my experts, we have a common approach, and it very much accelerates the way things happen. I think we can do that, and ultimately, all that is going to feed into the African Medicines Agency. We're going to recognize that there still will be national regulatory authorities in existence, so we have to put all of this experience and capacity together so that we get that efficiency and we get the sensitivity to new developments, to science. This is emerging. So we need a connection with the scientists as well and the policymakers to inform what decisions are made by such organizations. It's not easy when you have 55 countries. But that's, we have a chopped up map. That's part of our history of colonialism. And it's up to us to see how we overcome that as a united African continent. That's very important. Thank you.
Thank you so much. And at this point in time, I will thank our panel here, starting off, of course, with Dr. Matidiso Boyeti, the WHO Regional Director. Thank you so much for giving your time to us. And Dr. William Nyima from UNS, thank you so much for coming through. Ms. Lydia Zikomo, UNFPA Regional Director, thank you so much. And last but not least, Dr. David Parenia from the SAE President. Thank you so much for coming through. To the journalists, a reminder that tomorrow again at 11 a.m. is going to be just after the plenary. You can come through for another media briefing. Thank you. Thank you, ladies and gentlemen. And apologies for the noise. I think we will.
Thank you for the woman power present in the room, and it was so good to see a panel of speakers where women like you. Thank you so much.
Sorry.